All right, today we're tackling three things that are at the very heart of patient care: hygiene, mobility, and skin integrity. Now, it's really easy to look at these as just three separate boxes you have to check off. But here's the secret: for your exams and for real world nursing, they're not separate at all. They're a tightly connected system. So let's jump in and see how they all work together and what happens when that system starts to fail. So, I want you to keep this one big question in the back of your mind through our whole session today. We're not just here to memorize tasks, we're digging into the why, the pathophysiology. Why does something as simple as lying in bed for a single day set off this massive chain reaction in the body? Once you understand the why, you stop just doing tasks and you start thinking like a nurse who prevents problems before they even begin. So, here's our game plan. We'll kick things off with our three pillars. Then we're going to trace the dangerous domino effect of what I call the immobility cascade. After that, we'll do a deep dive on pressure injuries, from the risks to the actual staging. Then we'll flip the script and talk about proactive care, starting with hygiene, then mobility, and we'll wrap up with the absolute must-know safety rules you'll need for your exam. All right, first up, let's lock in our foundation, the three pillars. You've got to see this as a cycle, right? A patient's ability to move, their mobility, has a huge impact on their skin. If they can't move, their skin is going to be at risk, big time. And once that skin breaks down, their hygiene needs just got way more complicated, because now we're fighting off infection. And, it's usually when we're providing that hygiene care that we find new problems with their skin or their mobility. See, they're all talking to each other, constantly. Getting that is step one. Okay, so let's focus on the big troublemaker here: immobility. As soon as a person stops moving, it's like flicking the first domino. It sets off this chain reaction, this cascade that flows through literally every system in the body. So let's start with the heart and blood vessels. When you're up and walking around, your leg muscles are squeezing those veins, helping push blood back up to your heart. When you stop moving, that help is gone. Blood starts to slow down and just pool in your lower legs. And that slow, stagnant blood is the perfect recipe for a blood clot, a thrombus, to form. Just like that. Lying in bed creates the risk for a life-threatening DVT or PE. That's why we are so obsessed with getting patients moving. Now let's look at the lungs. Moving around, taking deep breaths, that all helps keep mucus moving so we can cough it out. But when a patient is just lying flat, all that mucus settles and pools in the bottom of their lungs. It's like a swamp. That gunk can clog up the tiny little airways, causing the air sacs, the alveoli, to collapse. We call that atelectasis. And that warm, wet, swampy environment, it's a paradise for bacteria, leading right to a nasty case of hypostatic pneumonia. And the urinary system, believe it or not, it all comes down to gravity. We need gravity to help our bladder and kidneys drain completely. When a patient is lying down, the bladder doesn't quite empty all the way. That leftover urine just sits there. That's urinary stasis. And it becomes a perfect breeding ground for bacteria, leading to UTIs. Plus, the minerals in that stagnant urine can start to form crystals, which can turn into painful kidney stones. And it's not just the internal organs. The body's whole framework starts to suffer. Without the normal stress of walking and moving, the body goes into breakdown mode. It starts chewing up muscle protein for energy, which leads to muscle wasting and weakness. And at the same time, the bones, realizing they're not needed as much, start leaching calcium out into the bloodstream. This leads to something called disuse osteoporosis, making bones brittle and way more likely to break. So all of this leads us right to the most visible consequence of being immobile: the breakdown of the skin. Let's really get into how a simple thing like pressure can cause so much damage. Okay, look at this image. This shows you exactly what's going on. When a patient's weight is pressing down on a bony spot, think the tailbone, the heels, the hips, it physically squishes the tiny little blood vessels, the capillaries, completely shut. Blood can't get through. That means no oxygen is getting to the tissue, which we call ischemia. If you don't relieve that pressure, the tissue literally starts to die. That's necrosis, and that, my friends, is a pressure injury. So when we're assessing our patients, we're on the lookout for a few key things. Immobility is number one, obviously. But we also look at nutrition. If you don't have enough protein, you can't repair damaged skin. We look for incontinence because moisture makes the skin weak and soggy. And this is a huge one: decreased sensory perception. If a patient can't feel the pain that's telling them, hey, you need to move, they're at an incredibly high risk. Let's walk through the stages. Stage 1 is your big flashing warning sign. The skin isn't broken yet, but you'll see a red area that's non-blanchable. That means when you press on it with your finger, it stays red. It doesn't turn white for a second. This tells you there's damage happening under the surface, and this is our golden opportunity to intervene before it gets worse. By stage 2, the skin is officially broken. The damage has gone through that top layer, and you now have partial thickness skin loss. You'll see the dermis, which usually looks kind of pink or red and moist. Sometimes it looks like a blister. Either way, the body's main shield against infection is now gone. A stage 3 is where things get serious. This is full thickness skin loss. The damage has gone all the way down into the subcutaneous tissue, and you can actually see the yellowish, fatty tissue. You might see some dead tissue, some slough or eschar, but you can still tell how deep the wound is. Stage 4 is the worst case scenario. This is full thickness skin and tissue loss. The wound is so deep that you can see or even touch the underlying stuff like muscle, tendon, or even bone. Now, there are 2 special cases you've got to know. On the left is unstageable. This means it's a deep wound, but it's so covered with gunk, slough, or eschar that you can't actually see the bottom. You can't stage what you can't see. And on the right is a suspected deep tissue injury, or a DTI. This looks like a deep, angry purple or maroon bruise that just won't go away. The skin might be intact, but it's a sign that there is major damage happening way down deep. Okay, enough doom and gloom. We've seen the problems. Now let's talk about solutions. And our first line of defense is proactive hygiene. It is so much more than just a bath. It's a critical assessment tool. Pay close attention here because this is a massive, must-know safety point. For most patients, soaking their feet is a nice, comforting thing to do. But for a patient with diabetes or peripheral vascular disease, you absolutely do not do this. Their circulation is poor, their sensation is poor. Soaking can lead to skin breakdown and infection they can't even feel. And clipping their nails? A tiny little nick could turn into an ulcer that never heals. For these patients, you never soak, you never trim. That is a hard and fast rule you will see on your exams. All right, our next proactive move is, you guessed it, promoting mobility. And that means knowing how to use assistive devices safely and correctly. You are definitely going to get questions that ask you to match the right crutch walking style or gait to the right patient. This table is your cheat sheet. So, for example, look at the 3-point gait. It says it's for when a patient can only bear weight on one leg. Think of a bad ankle fracture. So the patient moves both crutches and their bad leg forward, then they swing their good leg through. Knowing which gait provides the right amount of support is all about preventing falls. Okay, let's wrap this up. I want to leave you with 2 absolutely critical, non-negotiable safety rules that you need to burn into your brain. This one is so important because it feels counterintuitive. You see a red, sore spot and you think, oh, I should rub it to get the blood flowing. No, do not do that. That area is red because the tiny blood vessels under the skin are already injured and weak. If you massage it, you can actually break them, making the damage worse and turning a stage 1 into a stage 2. So remember, red skin means hands off. And finally, let's talk about something simple, shaving. If your patient is on blood thinners like anticoagulants, or their platelet count is low, they are a major bleeding risk. One tiny nick from a normal razor could bleed and bleed. That's why for these specific patients, you must use an electric razor. It's a simple, easy way to prevent a big problem. So as we finish up, just think about it. What is one thing you can do differently tomorrow to better connect these 3 pillars for your patients?